The following podcast is part of a certified educational activity titled Enhancing Diagnosis and Management of Retinal Diseases in Urgent Care. Access the entire activity and complete the post-test at peerview.com/AFV860. Downloadable slides and practice aids are also available.
Welcome, everyone. Today we're going to be discussing some ophthalmology topics in urgent care with a special focus on enhancing the diagnosis and management of retinal diseases. I'll be co-hosting. My name's Joe Toscano. I am an urgent care and emergency physician in the East San Francisco Bay Area, and I'll be joined by Dr. Pito Campochiaro, who's an ophthalmologist from Johns Hopkins. So we have some challenges in the front lines in acute care, in emergency medicine and urgent care when it comes to evaluating patients with visual and other eye complaints. This summary slide comes from a review of several studies based on ED data. We don't have urgent care data, but in my experience, the situation's pretty similar in both venues. There's also a study here that laments the fact that we learn how to use an ophthalmoscope in medical school, and then unless you go into ophthalmology, our proficiency with it goes down from there. So for our objectives today, we're going to discuss acute care ophthalmology a bit, but really hone in on the features of central retinal vein occlusion and the associated macular edema. We'll talk about the differential diagnosis, which overlaps with some other retinal conditions like diabetic retinopathy and diabetic macular edema. And then we'll also recognize the importance of and appropriate timing of ophthalmology consultation for these patients prior to discharging them from our clinics. I will start off our discussion. I think that everyone would agree that acute vision loss is a scary chief complaint for us. The differential diagnosis is broad and includes a lot of serious diseases. And because vision is so important, a misdiagnosis here can be disastrous for the patient and for us. Awareness and early recognition is important so we can make an appropriate referral. And because urgent cares don't have direct relationship with ophthalmologists, most of the time, that referral is going to be to the ED. But truth be told, patients might be better served by a quicker referral directly to a specialist. Let's start off with a case. This is a 58-year-old woman named Emma, and she presents to our urgent care with sudden painless loss of vision in one of her eyes, in her right eye. She woke this morning and noticed the symptoms. She does not have any headaches, slurred speech, other neurologic deficits. In the past, she's not had any surgery on her eye. There's been no trauma to the eye. She's not had any exposure to chemicals or other substances in the eye. She does note that she wears glasses for presbyopia. Other elements of her medical history include the fact that she has been diagnosed with diabetes and hypertension, and she's on medications for those, including lisinopril hydrochlorothiazide, as well as metformin and glipizide. Looking at her vitals, she's got a little bit of elevation of her blood pressure, but nothing dangerous. Heart rate is normal. She's afebrile. Respiratory rate is normal, and her oxygen sat is as well. So as we're reviewing the history that's been documented at the intake process, and most of that answers our usual questions, we have to think, are there any additional questions to ask the patient, and what kinds of questions should we ask ourselves as we begin to arrive at a diagnosis here? What factors are important? Is there anything we forgot to ask? What are we going to do next? Dr. Campochiaro, what are your thoughts here? Was the history complete? Is there anything more you'd like to know in terms of history?
Well, Joe, I think it was a good start. I think I would want to know a little bit more about the nature of the vision loss. Was it severe? Is it a pretty complete loss? Did it come on very suddenly, or was it more subacute?
Mhm.
And are there any associated systemic symptoms that are associated with this vision loss? I think we'll get into some of these in more detail, but those are some of the early questions that I'd want to think about.
Great, thank you. As we're thinking about our differential for Emma, as for any patient with vision loss, there are several possible conditions that should enter our minds. Each of these has an urgency or emergency status associated with it in terms of our referral to a specialist, and that has to do with basically the time-sensitive nature of any of the specific treatments for these. There's a chance of a poor outcome in most of these cases if there's undue delay. And really, none of these conditions are super common in our practice, so awareness is very important. So to help us learn about the details here, I'd like to more formally introduce my co-panelist. Dr. Pito Campacharo is the Eccles Professor of Ophthalmology and Neuroscience at the Wilmer Eye Institute, and that's part of Johns Hopkins University in Baltimore. Peter, welcome, and thank you for helping us understand this important topic more deeply and from a specialist perspective.
Well, thank you, Joe. Central retinal vein occlusion, or vein occlusion, indicates a thrombotic obstruction in one of the outflow vessels of the eye. And if it's in the central retinal vein, which is the main outflow channel that exits through the optic nerve, then the entire retina is affected, and that can be quite severe. If it's in one of the first order branches, either at the superior or inferior margin of the disc, then it's a hemiretinal vein occlusion, and half of the retina is involved. And if it involves a second or further order branch vessel, then it's a branch retinal vein occlusion. And maybe one quadrant or a little bit more than one quadrant of the retina would be affected. Now, branch retinal vein occlusion is the most common of the types of retinal vein occlusion. About 70 to 80% of the cases are branch retinal vein occlusion. About 20 to 30% are central retinal vein occlusions, and only 1 to 2% are hemiretinal vein occlusions. Now, retinal vein occlusion is the second most common retinal vascular disease, second only to diabetic retinopathy. It affects 16.4 million people globally. It increases with age, and the prevalence is about 5.2 per 1,000 individuals. Now, the way it presents is with unilateral painless loss of vision. Now, generally, it's not a complete loss of vision. It's not someone who can't see anything out of the eye. It's usually sort of a blurring of vision. And there usually is not an afferent pupil defect. If there is severe ischemia associated with it, there can be an afferent pupil defect. But if you see a brisk APD, then you should think of other things possibly like a central retinal artery occlusion or a retinal detachment. Now, the real key to diagnosis, the history and everything can be very useful, but it's the fundoscopic exam that really tells you the diagnosis. And if it's a central retinal vein occlusion, generally what you see is numerous hemorrhages throughout the retina, like this picture on the right. There also can be cotton wool patches, which are little infarcts, and exudates. And it's generally described as a blunted and thunder appearance. It can be quite dramatic. Now, if it's a branch vein occlusion, you see the retinal hemorrhages confined to about a quadrant or a little bit more quadrant of the retina, either superiorly or inferiorly. Now, the risk factors for retinal vein occlusion are older age. Almost always it's in patients over the age of 50. There are vascular risk factors such as hypertension, hyperlipidemia, diabetes. And the reason for that is that these vascular risk factors compromise vascular endothelium, including the vascular endothelium within the retinal veins. And that makes them less likely to protect against thrombosis. Open-angle glaucoma is a risk factor because the increased pressure in the eye causes bowing back of the lamina cribosa. And the lamina cribosa is a connective tissue structure within the optic nerve, and the central retinal vein passes through that. And with this bowing back, it can cause kinks in the central retinal vein, which results in turbulent blood flow, which increases the likelihood of thrombosis. And any drug, such as oral contraceptives, which increase hypercoagulability, is a risk factor for vein occlusion, as is any systemic condition, which increases the likelihood of hypercoagulability, such as polycythemia vera, or any increase in platelets, or any condition which increases proteins to a large extent in the serum. Now, factors that raise a suspicion of systemic disease are bilaterality, because usually it's only one eye that's affected, and if both eyes are affected, then it becomes more likely that there's some systemic thing that's contributing. Now, it's also more likely to be unusual and associated with systemic problems if it occurs in someone who's less than 50 years old, or if there are associated systemic findings. Now, the most common complication of retinal vein occlusion is macular edema. And the reason for that is that the circulation in the eye is a closed system, so that the blood enters through the central retinal artery, it goes to branch arteries and then to capillaries, and then flows back through the venous system to the central retinal vein and out of the eye. So when there's an obstruction in the outflow vessels, this increases vascular resistance, and that decreases perfusion in the eye. And that decrease in perfusion leads to retinal ischemia, and it can be a profound reduction in retinal ischemia if there's a lot of pre-existing arterial disease, or it can be a modest amount. But that retinal ischemia results in upregulation of hypoxia-regulated genes, including vascular endothelial growth factor, or VEGF. And the increased levels of VEGF result in vascular leakage within the eye. And the leakage from the blood vessels causes collection of fluid in the macula, which is what macular edema is. And this causes reversible reduction in vision. Now, if the ischemia is severe, then abnormal blood vessels can grow, neovascularization. They can grow on the surface of the retina and recruit other cells that result in scar tissue on the retina, which can result in traction retinal detachment. And if the ischemia is particularly severe, this can cause neovascularization to grow on the surface of the iris, and those vessels can grow into the trabecular meshwork, the outflow channels of the eye, resulting in neovascular glaucoma, which is a particularly severe complication. Now, when you're faced with a patient who complains of acute or subacute vision loss, as I mentioned previously, it's important to know whether it's one eye or both eyes, and whether there's associated pain and redness of the eye. Pain and redness suggest inflammation, and in an uncomplicated vein occlusion, you don't usually see that. You want to know the extent of the retina that's involved, and whether the loss of vision is profound or blurring. If it's profound, it makes you think of some other things, such as a retinal artery occlusion or a retinal detachment. And the timing can be a useful hint. If it's particularly sudden, if the patient can say, my vision went out at 10 o'clock this morning, that usually indicates something like a retinal artery occlusion, not a retinal vein occlusion. And if it's a temporary occlusion, if the vision went out and then came back, that's generally an indication of amaurosis fugax and embolic disease. Then it's always important to do a good review of systems to see if there are systemic associations. As far as the exam, the visual acuity is important. Again, with retinal vein occlusion, it's usually blurring. It can be in the range of 2200 or 2100. It's good to know the intraocular pressure, but if you don't have a tonometer, it's not necessary. You can assess that by palpation, because you really want to know only if it's really severely elevated. And then the rest of the eye exam, looking at the extraocular muscles, visual fields, confrontation visual fields are useful. If there's a profound field defect in one quadrant of the retina, it makes you think more of a retinal detachment. But the real key, again, is the fundoscopic exam. And the first thing to mention about fundoscopic exam is it's really important to dilate the pupil. I know sometimes there's concern about precipitating angle closure glaucoma, but really that's very unusual. And if you do happen to do that, it's treatable. And it's important for a patient to know about that predisposition so you can actually be doing the patient a favor. So the risks of dilating the pupil are far less than the benefit you gain from being able to do a good fundoscopic exam. The first thing you do is you look at the optic disc, look at the margins, see if they're sharp. With a vein occlusion, there's often some disc edema. The retinal vessels with a central retinal vein occlusion are often dilated and tortuous. And as I mentioned previously, hemorrhages are the key finding. Usually many dot and blot hemorrhages throughout the entire retina with a central retinal vein occlusion, or if in a quadrant with a branch retinal vein occlusion. Now, if there are not hemorrhages, you may look at the macula and see that there are drusen along with some focal small hemorrhages and some edema, and that would indicate to you the possibility of wet macular degeneration. And then it's always important to look out in the periphery and see if there's any elevation of the retina, which is an indication of retinal detachment. Now we're going to just briefly look at a video about fundoscopy.
Looking directly into the pupil, you'll see an orange-red color first, which is the retina. Now move around, adjusting the lens power until some feature comes into focus, and often this is a retinal blood vessel. So retinal blood vessels consist of paired arteries and veins, with the veins being wider in caliber and darker in color. Follow the course of a pair of vessels to get familiar with what normal looks like, and look for abnormalities such as vessel tortuosity and AV nipping, seen in systemic hypertension, and venous beading, which is seen in severe diabetic retinopathy. Also look for perivascular abnormalities such as cotton wool spots and retinal hemorrhages, which are seen in conditions that include diabetic retinopathy and retinal vein occlusions. Examine all 4 of the retinal vascular arcades, which emanate from the optic disc in the inferotemporal, infranasal, supranasal, and supratemporal quadrants. As you do this, track the vessels towards the optic nerve, which is located in the nasal aspect of the fundus. So remember, the nerve is nasal. Another clue is that any V shapes created by vessels point towards the optic disc. Once you find the optic disc, it will fill up most of the 10-degree view of the ophthalmoscope. Assess the 3 C's of the optic disc, which are the color, the cup, and the contour.
Now, many of you have slit lamps available to you in the urgent care setting. You don't have to be an expert in a slit lamp exam to get some useful information. The first thing you want to do is to look at the conjunctiva and see, are there many dilated blood vessels? Is the eye red? Of course, you can see that just from your external exam as well. But if there's a lot of redness, dilated blood vessels, that's an indication of inflammation. And that makes central retinal vein occlusion or vein occlusion less likely unless there's neovascular glaucoma. You also want to look to see if there's any indication of penetration site in the conjunctiva. Naturally, as part of your history, you're going to be asking about the possibility of trauma, or was the patient in a situation where trauma was possible, such as hammering metal on metal. But you look at the conjunctiva to see if there's any blood in it or any areas where there's a penetration site. And then you look at the cornea and look at the surface to see if it's nice and regular and with no defects. Is there a penetration site in the cornea? Is there a corneal abrasion, which is, just a defect in the epithelium? A corneal abrasion can cause substantial vision loss, so it can present with relatively acute vision loss, but it's almost always associated with pretty significant pain. Then you look in the anterior chamber, and you don't have to be an expert at finding cells and flare, but you want to know, is it relatively clear in the anterior chamber, or is it cloudy? If it's cloudy, that's suggestive of inflammation. and you want to look for layered areas. If there's a red layered area at the bottom of the anterior chamber, that's a hyphema. And that's an indication of hemorrhage within the eye. So it can be due to trauma or it can be due to bleeding blood vessels. If you see a hyphema, you want to look carefully at the surface of the iris to see if there are a lot of blood vessels, dilated blood vessels, which is an indication of neovascularization on the iris and could indicate neovascular glaucoma. If there's a white layered area at the bottom, this is generally due to fibrin and white cells, and that's an indication of inflammation and can indicate endophthalmitis, which is another very urgent situation that needs immediate referral. Now, it can be useful to use ultrasound in the urgent care setting, and Joe is going to go through a few key tips about ultrasound in that setting.
Yeah. POCUS is not that useful in diagnosing retinal vein occlusion, but it's pretty good for some other conditions that are in the differential for visual loss or other visual complaints, including retinal detachment, vitreous detachment, and vitreous hemorrhage, as well as lens dislocation and actually intraocular foreign bodies. I use this a fair amount in my ED practice in the eye and elsewhere in the body, but I don't have it yet in the urgent care where I work. However, at the last national conference in urgent care, the didactic session and several hands-on sessions that we had in point-of-care ultrasound were among some of the most well-attended. So that tells me that this is an up-and-coming area of importance in urgent care and certainly an area of interest among clinicians. POCUS is pretty easy to learn and interpret, and we're even seeing AI enter into this space, both in terms of performing the ultrasound as well as interpreting it. And that can be useful for those who are just starting out. POCUS is really a great extension of our physical exam. The only real contraindication is if you suspect a globe rupture or perforation. And if that's the case, your exam stops right at that point in terms of your suspicion and finding some of those signs of that disease entity. In terms of performing the point of care ultrasound of the eye, you want to get some gel between the probe and the eye, and it's best to have the eye closed during that. In most cases, we're going to put a piece of tegaderm over the closed eye, put the gel on there, and then use the ultrasound probe in the gel. You can use an ultrasound pad if you have one, but those are usually less available. You're going to use a high frequency linear probe to do the imaging, and you're going to scan axially, so kind of horizontally, and then turn into the sagittal plane or 90 degrees. And you're pretty much going front to back with your images, and you'll see everything you need to in that using that technique. Here's some examples of some of the things that you might see with some of the disease entities that ultrasound's good at identifying. On the far left is a retinal detachment. You can actually see the contour of the retina detached from the back surface of the eye. There's fluid that gets behind the retina in that case, so that looks hypoechoic, and it's actually very interesting. Just looks like a retinal detachment, even if you're not used to looking at ultrasounds, what you imagine it would look like. With a retinal detachment, it's going to almost always be tethered to the optic disc, and that's one of the clues to distinguish it from some of the other things that can sort of look like it. On the far right is vitreous hemorrhage. That can occur with trauma or spontaneous bleeding from something like proliferative diabetic retinopathy, or as a complication of a vitreous detachment. That echogenic, whiter looking fluid compared with the black at the top of the picture, which is the anterior portion of the eye, is blood that's filling that space between the vitreous and the back part of the eye and the retina. The middle picture is of a vitreous detachment. And in this case, as we age, it's one of the things that could just happen spontaneously. The portion of the vitreous humor that's gel converts somewhat to a more liquid component, and sometimes that liquid component can escape from the vitreous body itself. In that case, the more gel component condenses, and that's what appears hyperechoic on the picture, a little bit whiter. That fluid that's escaping from the vitreous can fill that space behind that condensed vitreous material now, and looks hypoechoic between the vitreous, the condensed vitreous, and the back part of the eye. A lot of times it looks very similar to vitreous hemorrhage, but a lot of times the distinguishing factor is that there's sort of a bright or even a more hyperechoic border to the condensed vitreous. It's the interface between that condensed vitreous and the fluid around it that gives you that almost like a pleural line that you see in a chest X-ray with a pneumothorax. But it has a little bit more variability in it than the other entities. So let's step back from ultrasound, which we didn't necessarily use in this case, but back to our case patient, Emma. And we have some more exam data now here. We know that she has sudden painless vision loss in her right eye, so she's certainly has a history that's compatible with central retinal vein occlusion or any venous occlusion, and she has those risk factors that we talked about. Her visual acuity is pretty bad on the right, 2400. On the left, she's 20/25, and with both eyes, 2200. She does not have any afferent pupillary defect. Her pupils look normal, and they're reacting normally bilaterally. There is no deficiency in her extraocular movements. You test visual fields to confrontation, and there's no abnormalities there. If you have tonometry, it's measured in normal, which is typical in these cases. But again, as Dr. Campochiaro said, if we don't have tonometry, sometimes we're not worried about, again, a perforation or penetrating eye injury. We can just get a basic sense with the eyes closed of touching the eyes. You always have the other one to compare, which is good. And mostly in this case, you're looking for a really elevated pressure to put you in a different range for your differential. And then finally, you perform fundoscopy. And on this, you notice that the retinal veins are dilated, that there are those patchy diffuse retinal hemorrhages, that blood and thunder appearance, and then the optic disc looks swollen. So Peter, what are you thinking about with this patient?
Yeah, Joe, I think that the presentation of this patient is pretty typical of a central retinal vein occlusion. So that would certainly be at the top of the list. But the other things you want to think about and rule out, one is, retinal artery occlusion. Whenever there's sudden vision loss and you're entertaining the thought of central or of a vein occlusion, make sure to think about, could this be an arterial occlusion? Because that requires generally some additional urgent workup. So it could be a temporary sudden loss of vision and then return of vision. That is either a TI called a TIA or amaurosis fugax. That's usually indicative of embolic disease. And so when that is a concern, you have to do a workup for source of emboli, the carotid or the heart, and a stroke workup. And, if you have a permanent sudden decrease, usually profound decrease in vision, that could indicate a central retinal artery occlusion. And that, again, can indicate embolic disease, which requires the workup to look for the source of emboli and a stroke workup. But in addition, a central retinal artery occlusion can occur from thrombosis in the setting of giant cell arteritis. And so if you're faced with that, you have a central retinal artery occlusion, you want to get a SED rate and a C-reactive protein levels, because they're often pretty highly elevated for giant cell arteritis. You also, want to ask about headache and pain in the temporal area and muscle weakness. Polymyalgia rheumatica is associated with giant cell arteritis. So you want to know about those symptoms to see if you're more concerned about giant cell arteritis. And that also is a very urgent situation. Generally, you want to get a quick ophthalmology consult and rheumatology possibly, because if it is giant cell arteritis, the patient should be started on high-dose systemic steroids and then scheduled for a temporal artery biopsy. Now, if the patient has a pretty acute sudden loss of vision, but you look in and there's no hemorrhages, you want to look carefully to see if there's any elevation of the retina, which would indicate a retinal detachment. And of course, if you look in and you can't see very much, you see hemorrhage, that indicates a vitreous hemorrhage. You want to know about if there's been trauma, if the patient has diabetic retinopathy. And this is when the ultrasound that Joe explained can be very useful to assess what's going on with the retina behind the hemorrhage. Now, again, in terms of the differential for central retinal vein occlusion, other causes of acute vision loss, the thing at the top of your mind is, could this be a central retinal artery occlusion? Because as we discussed, that indicates that there could be embolic disease, which needs to be evaluated, or it could be a sign of giant cell arteritis, which requires additional testing, the SED rate and C-reactive protein, and if it's a high suspicion, immediate action with high-dose steroids. Retinal detachment, again, if you look in, you don't see a lot of hemorrhages, but you see an area of elevation of the retina. That indicates a retinal detachment, and that requires, an immediate consult with ophthalmology, particularly if the macula is not involved. If the macula is not involved, that's generally a very urgent situation because we like to repair the retina before the macula becomes involved. And then diabetic retinopathy can present very much like central retinal vein occlusion, but it's a patient who has a history of diabetes, and usually it's bilateral involvement. And mistaking a diagnosis of diabetic macular edema versus macular edema from central retinal vein occlusion is not a big deal because the treatment is the same. Now, if you look in and there's not a lot of hemorrhages throughout the retina, but drusen in the center and maybe a few flecks of hemorrhage and some edema, that should raise the suspicion of wet age-related macular degeneration. Now I'll hand it back to Joe for a discussion about referral and continuity of care.
Yes, I'll pick it up from here. Beyond the conjunctivitis, foreign bodies, and styes, which are in our typical wheelhouse of the range of other eye issues that can be seen in urgent care, a number of them require evaluation by an ophthalmologist as soon as possible. So if you have a relationship with someone, you would consult with them, and then they would tell you either send them to the office or the ED based on the resources that were needed. And if you don't, these folks in this immediate category are going to go right to the ER. These include, as Dr. Campoggiaro mentioned, patients where we think or can confirm that they have a central retinal artery occlusion. This is evaluated and treated a lot like a stroke. Most stroke neurologists will thrombolyse these patients if there's no contraindication. But also falling into this category is patients with acute glaucoma or endophthalmitis, patients with giant cell arteritis with visual complaints, and then patients with acid or alkali exposure or other chemical burns of the eyes. Those patients need to be seen as soon as possible, as soon as we're done irrigating them and confirming that the pH has gotten back to normal. Of course, that's vital initially. Slightly less acute, but still emergent, include the conditions of an open globe, so perforation or penetrating globe injury, hyphema, infectious keratitis, and also the retinal detachment that we talked about. Patients with central retinal vein occlusion, like our patient Emma, or patients with optic neuritis, uveitis, and vitreous hemorrhage, need to see an ophthalmologist quickly as well, but their referrals can wait for about 24 or 48 hours. So again, looking back at some ED studies to inform us about how communicating the need for and the timeliness of ophthalmology follow-up translates into action. These were patients that were seen in the ED. From the numbers that they saw, they projected that over 2 million ophthalmology-related ED encounters occur in the United States each year. And of them, a little under half, up to about 3/4, require some follow-up in an outpatient eye clinic. Unfortunately, only about 1/4 to 1/3 of them actually kept their follow-up appointments. And these were patients that were actually seen in the ED by an ophthalmology attending or a resident. There were some common denominators in those who didn't follow up. Among them were patients who were younger in age, who didn't have insurance or were out of work, or patients who kind of thought that their complaints or their eye issue was not a big deal, that they had some sense that it was non-vision threatening, or there was no change in their vision from baseline, or their vision was just normal. And that somewhat makes sense. But it's still important, and these are patients we need to maybe pay more attention to because all of the patients who had follow-up appointments in this, which again were up to 3/4, did require either further diagnostic testing or had the initial diagnosis of a chronic eye condition that needed further treatment. And then, of course, where these patients come when they don't get to their specialist, they come back to the ED or the urgent care, and we're seeing them again for something that really they should have already gotten plugged into that specialty care for. So what are some of the things that have been shown to help with follow-up? One of the studies that informed us about how bad the follow-up can be was that TAN study. And they actually looked at before and after using some focused interventions. And these are some of the things that they found helped. We as clinicians have control of some of this, like determining the urgency of the needed follow-up, as well as documenting that we made the referral. Our staff can help with real-time scheduling. Of course, the insurance issues that could get in the way here are a lot more complicated and would require a lot more than an hour to fix or talk about. But the connection to the specialist is super important here. And if the patient already has an ophthalmologist, that's a great start. Sometimes they need ophthalmology subspecialty care, but if they have a general ophthalmologist, that can help as your first call. And if they don't, do consider, rather than the knee-jerk ED referral, seeing if your practice can arrange something directly with an ophthalmologist. Now, this requires advanced planning. It's usually something that your medical director or clinical lead is going to do. Identify an ophthalmologist who is willing to take calls from the clinic and help with those urgent treatments and helping decide on the urgency of a referral. Even as a clinician, though, I can remember being challenged by this early in my urgent care career. And I was at a visit with my own ophthalmologist, and I think within the past couple of months had had difficulty getting some ophthalmology follow-up for a patient, and so sent him to the ER, but asked my ophthalmologist if he'd be willing for me to call him for an occasional urgent care patient, and it actually turned out to be a great referral source for me, and actually my colleagues in the urgent care used him as well. So specifically in terms of follow-up for retinal vein occlusion, that follow-up needs to be, as we said, within 24 to 48 hours. The risk factors for developing and worsening eye diseases include hypertension, diabetes, and smoking, which we talked about. And the primary care doctor is important in helping modify these risk factors into the future so that the eye disease doesn't get worse. So referring back to the primary care physician is important there as well. If there is some sense that there's a rheumatologic or other systemic disease that's part of the presentation, that requires prompt follow-up. Sometimes the PCP can do that, or it might require referral to a hematologist if the initial hypercoagulability or initial evaluation is inconclusive. And again, you're going to suspect that in patients who don't have those traditional vascular type risk factors, patients with bilateral issues or other systemic symptoms in their review of systems. So Peter, I understand you're at a quaternary center, but how does referral go there? Do you guys have similar challenges? What works to get a patient from the front lines into your clinic? And also, how does the coordination with primary care and other specialists go for you and your group?
Yeah, so Joseph, we really have to cooperate with our urgent care colleagues, and we try to be very accessible. So with we like to have a triage approach where they can call and talk to either one of a faculty or a fellow and determine if that patient needs to be seen that day. And then we just have the patient come down and see them immediately. I think that sort of accessibility is really key for some of these urgent cases with acute visual loss.
Great. So to wrap up, Emma has a central retinal vein occlusion and macular edema. And in my discharge of her, it's important for me, after I've figured out where she's going to go in that 24 to 48 hours, to let her know that it requires a specialist and that she needs to keep follow-up in that time. The risks associated with her not doing that, or this not being treated or inadequately treated or treated too late, is that it could result in worsening vision, and that's something she needs to understand. Dr. Compucciaro will talk a little bit more about this next, but I can explain to her that the treatment for this particular condition involves a variety of medications, not the drops we usually use like antibiotic eye drops or similar. but that's what the treatment's going to entail when she sees the ophthalmologist. Peter, so how about explaining more in terms of how a specialist treats retinal vein occlusion retinal vein occlusion and other retinal diseases?
Yeah, so I think a lot of this information is primarily for you urgent care specialists. The patient doesn't necessarily have to get into this level of detail. In terms of your instructions to the patients, the key thing, as Dr. Toscano mentioned, is to really hammer home that this is reversible vision loss and that there are very effective treatments that can, in many cases, bring the vision back to normal levels. But it's absolutely key that they follow up and get the care that they need. Now, if they really want to know some of the details, you can explain to them that the treatment is because there's these elevated levels of VEGF, that we have good medications that can be injected into the eye that neutralize the VEGF and that therefore reduce the leakage and result in resolution of the edema. Now, commonly used ones, one that's not listed here is bevacizumab, which is used systemically for cancer, and we use it locally. It's the most inexpensive alternative, and many insurance companies require that you start with that. But the most commonly used one is aflibercept, the 2 milligram, which is approved for retinal vein occlusion as well as diabetic macular edema and wet AMD. There's also now an 8 milligram dose, which is available for wet AMD and DME, not for retinal vein occlusion at this point. Faricimab is a bispecific antibody that blocks both angiopoietin-2 and VEGF. And angiopoietin-2 contributes to the vascular leakage, and in some cases, blocking both can have a better drying effect, in patients who are not responding optimally to a specific VEGF-A antagonist like aflibercept. And then ranibizumab is a selective VEGF-A antagonist. It's not used as much anymore. Aflibercept is used more for injection, but it is used in a port delivery system, which is an implantable reservoir which slowly releases VEGF into the eye, or ranibizumab into the eye. And this is a very effective treatment and mitigates the need for really frequent injections. So patients who have this just require a refill exchange every 6 months. And the efficacy with this is extremely good. Unfortunately, it's not cannot be used for patients with retinal vein occlusion. It's not approved for that at this point. Now, the way that we do these injections is that we sterilize the eye with betadine, and then we anesthetize either with a subconjunctival injection of proparacaine or a lot of topical proparacaine, and often soaking a cotton tip and holding it in place to really anesthetize the site of injection. We generally can make this quite tolerable with very little pain, but I think there's always some anxiety associated with this. And so it's not, unless the patient really specifically asks about it, I don't think you have to get into it too much. You can leave it up to the retina specialist to explain exactly what's entailed with the injections. Okay, so our key take-home messages is that retinal vein occlusion generally presents as acute, relatively acute, subacute, painless loss of vision in one eye. You have to be cognizant of, are there vascular risk factors? It tends to occur in patients who are older than 50. If it's younger than 50, you're going to be more suspicious of some systemic associated finding. It's important to make the diagnosis and refer the patient within a few days or even a week is fine. But the key is that they follow up And so, if it's too remote, they're less likely to follow up. So you really want to try to get an appointment within a week. And then, our treatments are really effective. And, it's important to hammer that home so that they are more likely to follow up. Okay, we're now at the question and answer session. Okay, there's a question here about dilating the pupil.
Mhm.
The question is, can you rely on a darkened room? It's really not very optimal, because as soon as you shine that light, regardless of how dark the room is, the light is bright and it will constrict the pupil. So you're not really going to get a good fundoscopic exam unless you use drops to dilate the pupil. I don't think it necessarily represents a breach of the standard of care not to dilate the pupil, but I think if you really want to get a good look, you're really gonna have to do that.
I can say when I examine patients in the ED, I'll usually do a dilated exam. I was initially fearful, like you had mentioned when you were talking about it, Peter, that I was going to precipitate a narrow angle glaucoma incident with that. But as you said, it's treatable, and actual identification of the tendency toward that can actually do the patient a favor. So I, for probably 20 years, been doing dilated exams in the ED. When I'm in urgent care, we don't have the medications to do it, so I don't. But I agree, it's probably not standard of care for a non-ophthalmologist to dilate. I think you do your best, and that actually leads in, I think, to the answer to the second question, which is how does a non-ophthalmologist keep up fundoscopic or other diagnostic skills? And I assume maybe you mean slit lamp. I think the rest of the exam, visual fields and extraocular movements, are kind of a little bit relatively easy to do. But I think practice makes perfect with that. It was interesting that one of the studies, again, lamented the fact that we're probably the best at using an ophthalmoscope when we're a medical student. And unless you're an ophthalmologist, you just do it less and less and don't think about it. But if you do, then you'll get better at it. So I always like to grab the scope, focus through the full thickness of the eye, look at the retina, and you can even get a preliminary look at the anterior chamber as well with a direct ophthalmoscope. And same thing with the slit lamp. There's a lot of buttons on there, but I find I use two of them mostly. And once you're used to what those are, you adjust the intensity and then the narrowness of your slit, basically, and the height of it, and the rest of it just includes moving it around and looking at the eye systematically. So, I think practice makes perfect there.
Okay, and we have a question about how frequently patients with retinal vein occlusion get macular edema. It's very, very common, especially with central retinal vein occlusion. It's probably 70 to 80% or more with central retinal vein occlusion, and maybe 60% with branch retinal vein occlusion. And once they get edema, it can be very chronic. So we've studied the long-term follow-up, and basically after 2 years of injections, and pretty frequent injections, often every month to every 6 weeks, about 50% of patients get to the point where they no longer need injections. So, and it's more like 60% with central retinal vein occlusion still require injections. So it's quite a few patients who really need injections for a very long time. And I've been injecting some patients for 10 years. Can a patient have retinal vein occlusion and diabetic retinopathy at the same time? Yes, it's certainly possible. As I mentioned, macular edema is the most common complication of each, and the treatment is the same for each.
I see a question about point of care ultrasound that I can answer. What steps would you recommend for an urgent care clinic interested in starting POCUS to take to get started? So, if you have some experience, you've been trained in point of care ultrasound, let's say from an ED residency, and have used it for a bit, and now you want to apply that in urgent care, really all you need is the device. And there are several portable ones that are available now for a couple $1,000s. where you can tap them into a tablet or even your smartphone and get your images there. Usually the bigger images are going to be a little bit better and easier to interpret. If you haven't done this at all, but you're interested in starting it in your urgent care, there are several very good vendors who offer an analysis of your practice situation, help you pick a machine that's suitable, or an ultrasound device that's suitable for your practice, and even get people trained up initially. You can just Google. There are several vendors, like I said. You can Google, starting ultrasound in urgent care, and you'll get actually at least two or three that I know of, and they're all those two or three are very good. It is important, though, to know what you're doing. I think if you can use the ultrasound, it's very operator dependent. If you're not using it appropriately, getting your images appropriately, you will miss what you're supposed to be looking for, and everything might look normal. So for yourself being trained and other people, it's important to have a systematic way to know that they're operating it well. Somebody who's an expert should examine their technique. And then typically before they are completely released to use it as a diagnostic tool, there's going to be some proctoring. So you'd have a set of them doing 5 ultrasounds of the eye, let's say, and 5 ultrasounds of the abdomen or other parts of the body where you want to get some proficiency at. So, and then in terms of implementing a plan like that and having a plan, the vendors can help with that as well.
Now, there's a question here about time-critical interventions, and Joseph alluded to this a bit. If a patient comes in with a retinal vein occlusion, and it's very acute, so it happened that day or the day before, you can consider, if it's available to you, a thrombolysis, and referring to a stroke team and doing angiography and cannulating the ophthalmic artery is something that is done in some centers. Another temporizing thing is you can have a patient breathe into a paper bag, because CO2 will cause some dilation, and there have been some rare reports of emboli moving more downstream with that sort of dilation. But those are the main really acute things. Endophthalmitis is also very acute. You need an ophthalmologist generally, but what we do is do a vitreous tap for a culture and gram stain, and then inject antibiotics. The sooner the antibiotics are injected into the eye, the more likely of a good outcome. What is the role of telemedicine? There are remote non-mydriatic cameras that are available in which the pictures are sent to a reading center that can tell you what's happening in the fundus. And so I don't know how frequently that's available in an urgent care setting. You may know, Joe, but it is available in some diabetologists have it available in their office so that they know whether patients need referral for diabetic retinopathy. What are the best? Go ahead, Joe.
I was going to say I'm not aware of any tools in this regard in terms of being able to show the ophthalmologist the eye, although I have had some sort of gross pathology of the eye that I sent a picture to, texted a photo of the outer vision of the version of the eye to the ophthalmologist. Most of the time, I think this is a telephone call, so that's where our exam is important, to be able to communicate our findings to the ophthalmologist to help make the right decision.
All right, there's a question about, this is a very good question.
Yeah.
About, if you're going to dilate pupils, what do you do in terms of instructing for driving? I can tell you that we dilate every patient who comes into our retina clinic. Usually you only have to dilate one eye. And the other eye is perfectly fine for driving. If you have to dilate both eyes, usually a couple hours, and the vision starts to normalize. What the dilating does really is, it most affects near vision, but it does result in, some blurring in the distance, and some patients do feel uncomfortable driving. But generally, it's not a problem. And how should we navigate triage and referral if retinal detachment is suspected? Yeah, so if a patient comes in and they're complaining of flashing lights and floaters, even if they don't have a detachment, that's usually an indication of a posterior vitreous detachment. And this is one that you want to hook up with a retina specialist if at all possible. It's good to make prior arrangements, just as Joe did with his ophthalmologist. If you can sort of establish communication lines so that when you're faced with this, because this is not that unusual a situation. Posterior vitreous detachments are pretty common, and when you're faced with it, the patient needs to get a retinal exam within a day or so to see if there's a retinal tear. Because if there's a retinal tear, it can be treated with laser, but if it's not treated, then there's a greater likelihood that the retina can then detach, and then they often need surgery. So you can save the patient having surgery if you refer in a very timely manner patients with posterior vitreous detachments. But that generally requires having sort of an advanced agreement with a retina specialty group, so that when you have a patient who has these symptoms, you call up, let them know, and then the patient's seen right away.
We have time for one more. There's actually an interesting question here about best practices for distinguishing between acute eye or abnormality versus brain pathology. I'll maybe tell you my front lines analysis of that. You really have to feel comfortable with the patterns that you're going to see. Then there's no absolutes here. When you have brain pathology that involves the posterior circulation, let's say, your eye complaints are going to be accompanied by other posterior circulation complaints, things that have to do with the cerebellum, let's say. So coordination is going to be involved, as well as any eye changes or changes in vision. If it's a very small area of ischemia that maybe just involves a visual cortex, it should affect both eyes, and you're going to have hemianopsia or other sorts of things that go along with what the back part of the brain does for the eyes. If it's a single eye that has the complaint, unless it's an ophthalmic artery issue, typically you're going to think more about it being an eye problem. Now, we talked about amaurosis or even a central retinal artery occlusion. You have to feel comfortable diagnosing that. Those are acute eye issues that involve one eye that are vascular in a way, although it's an eye problem. So again, I don't think there's a systematic way to do it. Being familiar with the things that can go wrong and maybe some of the syndromic patterns that occur in terms of symptoms is important to have under your belt.
On behalf of Joe Toscano, I'd like to thank you for participating and for all the really insightful questions and discussions that we had. Thanks very much.
Thanks, everyone. Take care.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This program is supported by an independent educational grant from Regeneron Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/AFV860.